Okay, so we will discuss about the metabolic, sorry, diabetes mellitus. Okay, so in the diabetes mellitus is a metabolic disorder characterized by the persistent hyperglycemia, which is result of defect in the insulin secretion, insulin action, or both. Okay, diabetes mellitus is a metabolic disorder. Okay, it is the metabolic disorder which is characterized by the persistent hyperglycemia, which is result of defect in the insulin secretion or insulin action, or both. Insulin secretion defected is there, or it may be insulin action defect is there, or it may be both secretion and action. Okay, now we'll see the classification of the diabetes mellitus. So diabetes mellitus is broadly classified as type 1 and type 2, although rare causes of diabetes exist. Type 1 is about 5 to 10 percentage, and type 2 is about 90 to 95 percentage. Okay, autoimmune type 1 is the autoimmune destruction of beta cells of the pancreas result in the absolute insulin deficiency with patients requiring insulin to survive. Okay, there is the autoimmune destruction of the beta cells of the pancreas result in the absorption of the result in the absolute insulin deficiency with patients requiring insulin to survive. In absence of insulin action in muscle and adipose tissue, glucose is not transported into cells by the glutamate transporter. Okay, in the absence of the insulin action in the muscle and the adipose tissue, uh, insulin action in absence of the insulin action in the muscle and the adipose tissue, glucose is not transported into the cell by the GLUT4 transporter. Okay, will now type 2. So, it is caused by both insulin resistance and defect in the insulin secretion as a result of beta cell dysfunction. Okay, it's due to both insulin resistance and the defect in the insulin secretion from the beta cells due to beta cell dysfunction. Insulin resistance occur in skeletal muscle, adipose tissue, and liver, resulting in reduced glucose uptake in the skeletal muscle, impaired inhibition of the hepatic glucose output, and increased fatty acid production in adipose tissue, which stimulates the gluconeogenesis and triglyceride synthesis. Risk factors include obesity, lack of physical activity, increasing age, dyslipidemia, hypertension, certain ethnic group, genetic predisposition. Okay, these are the risk factor for this type 2 diabetes mellitus. Okay, so got it till that there that metabolic, sorry, diabetes mellitus is the metabolic disorder with persistent hyperglycemia due to result in the due to increase, sorry, insulin secretion defect, a defect in the insulin secretion or the insulin action, or both. Now classification in the type 1 diabetes mellitus, there is the autoimmune destruction of beta cells of the pancreas, which causes absolute insulin deficiency. So the patient have take insulin for the survival, and in absence of the insulin action in the skeletal muscle, in the muscles and the adipose tissue, glucose will not be transported by the GLUT4 transporter. And in type 2, caused by the both insulin resistance and defect in insulin secretion as a result of beta cell dysfunction. Insulin resistance is occur in the skeletal muscle, adipose tissue, and liver, resulting in the reduced glucose uptake in the skeletal muscle, impaired inhibition of the hepatic glucose output, and the increased fatty acids production in the adipose tissue, which stimulates the gluconeogenesis and the triglyceride synthesis. So the due to the gluconeogenesis and the triglyceride synthesis, the triglycerides and the glucose will be increased more and more in the body, which are the risk factors. So the obesity, lack of physical activity, increasing age, okay, dyslipidemia, hypertension, certain ethnic group, and genetic predisposition are the risk factor for this. Okay, then clinical features. So type 1 diabetes mellitus, osmotic symptoms. So osmotic symptoms are thirst, polydipsia, and the polyuria. For type 1 diabetes mellitus, osmotic symptoms, thirst, polydipsia, will take more and more water to drink, and polyuria, then dehydration, hypovolemia, and drowsiness, then blurred vision, and the cutaneous candida infection. Then catabolic symptoms. This was the osmotic symptom. Now the catabolic symptom. So muscle wasting, fatigue, and weight loss. Then diabetic ketoacidosis. Approximately 25% of the children with type 1 diabetes mellitus present with the diabetic ketoacidosis. So what is the etiology? So we will see the diabetic ketoacidosis. Okay, so in the etiology, there is the impairment of the glucose. Okay, there is the impairment of the glucose utilization in the peripheral tissue. There is impairment of the glucose utilization in the peripheral tissue leads to increased gluconeogenesis and glycogenolysis in the liver with consequent worsened hyperglycemia. Okay, impairment of the glucose utilization will result in the peripheral tissue leads to increased gluconeogenesis and the glycogenolysis in the liver will worsen the hyperglycemia. Then simultaneous counter-regulatory hormone hypersecretion, including cortisol, glucagon, and the catecholamine in tandem with insulin deficiency, causes release of free fatty acids into the circulation as a result of lipolysis in the adipose tissue. So the stimulus and the simultaneous counter-regulatory hormone hypersecretion will be okay. The cortisol, glucagon, and the catecholamine in the tandem with insulin deficiency will cause the lipolysis in the adipose tissue. Then free fatty acid undergo oxidation in the liver to produce ketone bodies. Okay, free fatty acid in the liver will undergo oxidation and will produce the ketone bodies, and subsequent ketonemia, as ketone bodies are weakly acidic. This cause increased plasma hydrogen ion concentration and metabolic acidosis. Okay, free fatty acid which is increased in the body will undergo oxidation in the liver to produce the ketone bodies. Okay, it will produce the ketone bodies by the oxidation of the fatty acid in the free fatty acid in the liver, and subsequent ketonemia, and will these ketone bodies will produce the ketonemia. As ketone bodies are weakly acidic, it will cause the increased plasma hydrogen level and will result in the metabolic acidosis. Okay, so characterized by the biochemical triad. This is characterized by biochemical triad, that the there is the hyperglycemia greater than 11 millimole per liter, then ketonemia greater than 3 millimole per liter, and the acidosis pH will be less than 7.3 plus or minus HCO3 minus will be less than 15 millimole per liter. What is the clinical feature? So, the symptoms and the signs. Okay, understood the this triad, biochemical triad. Okay, that the hyperglycemia. Okay, uh, hyperglycemia, then the ketonemia and the acidosis. Glucose will be high, ketone body will be high, and the H plus will be on higher side. What is the glucose value? It's the greater than 11 millimole per liter. Then the ketone bodies will be greater than 3 millimole per liter, and the pH will be less than 7.3. Okay. Now we will see the clinical features. So, symptoms and signs. So in the symptoms of the diabetes mellitus, the polyuria, polydipsia, thirst, lethargy, weight loss, nausea, vomiting, anorexia, abdominal pain, dehydration, headache, altered mental status. Okay, this is the symptoms of the diabetes mellitus, that the polyuria, polydipsia, thirst, lethargy, weight loss, nausea, vomiting, anorexia and abdominal pain, and the dehydration, headache and altered mental status. Then which are the signs of the diabetes mellitus? So dry mucous membrane, then ketotic breath, then the tachycardia, hypotension, Kussmaul breathing, focal signs of the precipitant, that's the infection. Okay, the signs of the DM is the dry mucous membrane, then the ketotic breath, and the Kussmaul breathing, then the tachycardia, hypotension, and the focal sign of the precipitating infection. Okay, now management. So in the management, uh, there should be fluid replacement, then insulin with glucose, then monitoring of the potassium plus or minus replacement, and treat underlying causes. Okay, why this occur? So the treat that cause. Okay, so we will give the fluid, then insulin with glucose, because if we give insulin only, there are more chances to have hypoglycemia, so we also have to give the glucose with that, then monitor potassium, and if required, then give the potassium, and last is the treat the underlying cause. Then this all were the type 1 diabetes mellitus. So as we have seen, that from the clinical features, uh, there is the osmotic symptoms and the catabolic symptoms. From there, then we have discussed that the diabetic ketoacidosis. Okay, so these occur in the type 1 diabetes mellitus. Then the characterized uh, biochemical triad. Then we have seen the clinical feature, their symptoms, and the signs. And lastly, we have seen the management. Okay. Now we will discuss about the type 2 diabetes mellitus. So in type 2 diabetes mellitus, just a minute, one third of cases are detected incidentally. Okay, In the type 2 diabetes mellitus, one-third of the cases are detected incidentally. Diagnosis is often delayed for many years, and the patient can therefore present with the complication from the prolonged hyperglycemia. Okay. The detection rate of the type 2 diabetes mellitus is very low, so when the patient come after so many times, the so many years, there will be complication are there because of the prolonged hyperglycemia. Then only about half of patient present with the classic symptoms of thirst, polydipsia, polyuria, and the tiredness secondary to the hyperglycemia. Okay, only half of the patient will present with the thirst, polydipsia, polyuria, and the tiredness due to the diabetes. Although these symptoms are less marked than the type 1 diabetes mellitus, they are very less compared to the type 1 diabetes mellitus. Then the hyperglycemia, glycemic hyperosmolar state, up to 25% of patients with type 2 diabetes mellitus present as HHS. That's the hyperglycemic hyperosmolar state. Okay, so what is the etiology of this HHS? Okay, hyperglycemic hyperosmolar state, 25% of patient present with this. So and other patients like uh, maybe present with the hypoglycemia. Okay, so we will discuss about that later. Now, HHS, hyperglycemic hyperosmolar state. Hyperglycemia hyperosmolar, its glucose level will be high, and the osmolar level will be also high. Osmolarity will be high. Okay, that's called the HHS. What is the etiology though? So the prolonged hyperglycemia from the insulin resistance or insulin deficiency result in the osmotic diuresis with renal sodium and potassium loss. Okay, will present will result in the osmotic diuresis with renal sodium and the potassium loss. This result in the extracellular volume depletion and dehydration with raised serum osmolality. Then ketosis, ketonemia does not typically occur in the HHS. Ketosis or ketonemia will not occur in the HHS because some insulin is still present and the hyperosmolality can inhibit lipolysis. Okay, hyperosmolality will inhibit the lipolysis. Okay, and the ketosis or ketonemia does not typically present because some insulin is still there. Then characterized triad. So the hypovolemia, what is the triad here? So there will be the hypovolemia, decrease water, decrease, sorry, volume, then marked hyperglycemia, increase glucose greater than 30, without significant hyperketonemia or acidosis. Without significant hyperketonemia or acidosis, and osmolality will be greater than 320 and increase high osmolarity, which is greater than 320. Okay, so we can see the decreased volume, then increase glucose greater than 30, hyperglycemia, and the increase osmolality greater than 320. Then clinical features. So polydipsia, polyuria, impaired cognitive function, tachycardia, hypotension, and the seizure. Okay, polydipsia, polyuria, impaired cognitive function, tachycardia, and the hypotension. and seizure are the sign of this type 2 diabetes mellitus. Okay, then management: treat the underlying cause, fluid replacement plus or minus insulin, correct electrolyte imbalance, and treat with poly prophylactic anticoagulant. Okay, so management is to treat the underlying cause, then fluid replacement, electrolyte imbalance, and the treat with the prophylactic anticoagulant. Okay, cause then the fluid, then the electrolyte imbalance should be treated, and last one is the anticoagulation, prophylactic anticoagulation should be done. Then diagnosis. So glucose concentration criteria. How can we diagnose that this is the diabetes mellitus? Okay, so uh, in sympathetic individual, in symptomatic individuals, example like thirst, urea, polydipsia, and the unexplained weight loss. Uh, Random venous plasma glucose concentration will be greater than or equal to 11.1. Then fasting plasma glucose concentration should be greater than or equal to 7, and 2-hour plasma glucose concentration should be greater than or equal to 11.1. After 75 gram anhydrous glucose in an oral glucose tolerance test. Then in asymptomatic individual, at least one of the above criteria fulfilled uh, on two separate occasions. At least one of the above criteria fulfilled on two separate occasions. Okay, from any of the two should be there. Okay, that's the venous plasma glucose concentration should be greater than or equal to 11.1, and the 2-hour plasma glucose concentration should also be greater than 11.1 after 75 gram anhydrous glucose taken in the oral glucose tolerance test, and the fasting plasma glucose concentration should be greater than or equal to 7. Okay, at least one of the above criteria should be there. Then HbA1c criteria. HbA1c greater than or equal to 48 millimole or 6 greater than 6.5 percentage. Confirm with second sample unless individual is symptomatic with plasma glucose which is greater than or equal to 11.1. When confirmation is not needed, and be not to use in children and young people. Okay, type 1 diabetes mellitus symptom onset within 2 months pregnancy, drugs causing hyperglycemia. Okay, uh, so in this uh, within 2 months, type 1 diabetes mellitus symptoms will seen within 2 months of pregnancy, and drug causing hyperglycemia, that is the steroids or blood conditions affecting the HB, hemolytic anemia, blood conditions affecting the hemoglobin cause the hemolytic anemia. Okay, now which are the complications? So microvascular and the microvascular. Okay, so in the complication, microvascular, the ischemic heart disease, that is the angina or ACS, then the cerebrovascular ischemia, that's the TIA or stroke, transaminated intravascular coagulation and the stroke, angina, and the acute coronary syndrome. And the peripheral vascular disease like intermittent claudication, acute ischemic limb, and the foot ulcer. Okay, peripheral vascular disease like will produce the intermittent claudication, then the acute ischemic limb, and the foot ulcer. Then, what is the complication in the microvascular? So, autonomic neuropathy, then the mononeuropathy, then the diabetic peripheral neuropathy, diabetic nephropathy, and the diabetic retinopathy. Okay, autonomic nephropathy, resting tachycardia, postural hypotension, cardiac ischemia, and sudden cardiac death. Okay, will cause the resting tachycardia, postural hypotension, cardiac ischemia, and the sudden cardiac death, gastroparesis, constipation or diarrhea, and the esophageal dysmotility. Okay, then the erectile dysfunction, there is the neuropathic bladder. Okay, erectile dysfunction and neuropathic bladder. Then mononeuropathies like often cranial nerves 3 and 6, median ulnar and radial nerve. Okay, often cranial nerves 3 and 6, and the median ulnar and radial nerve, medial ulnar and radial nerve. Then the diabetic peripheral neuropathy, glow and Stokins distribution, and foot ulceration. Okay, then the diabetic nephropathy, CKD, and the diabetic retinopathy, blindness. And lastly, hypoglycemia. So in the hypoglycemia occurs when the plasma glucose falls below 4 millimole per liter. It commonly occurs as a result of insulin therapy. It can also occur with certain oral hypoglycemic agent. In individuals without diabetes, the normal response to the hypoglycemia comprises reduced insulin secretion from the pancreas and increased glucagon release. A number of counter-regulatory hormones, including norad, cortisol, and growth hormone, norad, cortisol, and the growth hormone, okay, uh, are also released. With diabetes, this response are reduced. With diabetes, this response are reduced, especially with the recurrent hypoglycemia and with increased duration of the disease. This can result in the hypoglycemic unawareness. Okay, this is called the hypoglycemic unawareness. Now that a number of counter-regulatory hormones like insulin, including norad, cortisol, and growth hormone are also released in patient with diabetes. These response are reduced. Okay, so this will norad, cortisol, and growth hormone will not released. Then clinical features of the hypoglycemia. So autonomic symptoms, then neuroglycopenic symptoms, and other symptoms. In other symptoms, nausea, fatigue, and hunger will are there. Any suspected hypoglycemia should be managed as an emergency and treated immediately to return blood glucose to the normal range. Suspected hypoglycemia should be managed as an emergency and treated immediately to return blood glucose to the normal range. Okay, clinical feature: the autonomic symptoms include sweating, feeling hot, anxiety, agitation, palpitation, shocking or a shaking, then paresthesia and the dizziness. Okay, paresthesia, dizziness, and the shaking, then palpitation, anxiety or agitation, sweating, and feeling hot. Then the neuroglycogenic symptoms. So weakness, blood vision, neuroglycopenic symptoms, that's the weakness, blood vision, difficulty speaking, poor concentration, poor coordination, drowsiness, confusion, seizure, coma. Okay. Weakness, neuroglycogenic, so there is the weakness, blood vision, difficulty in speaking, poor concentration, poor coordination, and drowsiness, confused, seizure, and coma. Other symptoms are nausea, fatigue, and hunger. Any suspected hypoglycemia should be managed as an emergency and treated immediately to return the blood glucose to the normal range. Okay, any suspected hypoglycemia should be managed. Okay, thank you.